Welcome to the How to Use Your Quarterly Hospital Readmission Report conference call. My name is Richard and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. During the question and answer session, if you have a question, please press star, then 1 on your touch-tone phone. I'll now turn the call over to Rob Skatsky. Mr. Skatsky, you may begin.
Thank you, Richard. Good afternoon, everyone. My name is Rob Skatsky, and I'd like to welcome you to today's webinar, How to Use Your Quarterly Hospital Readmission Report, presented by the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of 3 organizations, Enpro in Michigan, Stratus Health in Minnesota, and Medisar in Wisconsin to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We know that you and your organization are working hard to improve healthcare quality and outcomes while preventing unnecessary patient readmissions. We hope that what you learned today will help you be successful in all these efforts. This session is being recorded and will be available for viewing on the LSQIN YouTube page in about 2 weeks. The link to the PowerPoint presentation is also available in the chat box. From this learning session, we hope to accomplish the following objectives. First, we want you to understand the content of your facility-specific readmission report, and we will go over this entire report very shortly. We also want you to be able to use the report to identify trends in readmissions and opportunities for focus. We want the report to be actionable and for you to be able to take the information and apply it within your workplace that will bring about improvement and meaningful change. And finally, from this presentation, we hope that you are able to explain the results to members of your organization to increase awareness about readmission trends. It is also our hope that this report can help foster an appreciation of data within your workplace. Over the last decade, we have seen great advances in the amount of data that is collected. Access to vast amounts of data along with advancements in analyzing and understanding the data can lead to positive change that can be spread more broadly. Few areas have benefited from this as much as the healthcare field. We see that data in healthcare is collected in a number of different ways, whether it be through patient records in an electronic health record system, population health statistics, the results of patient satisfaction surveys, or patients' claims data. Data is being used more and more to identify gaps and drive decisions. Using this data-driven decision process can reduce waste, increase profits, create efficiencies, and most importantly, lead to better patient outcomes. And that's really what we want to achieve with these reports. We want to provide you and your hospital staff with as much information as possible about your facility and your patients to enhance your ability to make meaningful and lasting improvements. Very briefly, the contents of the readmission report are as follows. First, the analysis in the report is solely about your Medicare fee-for-service patient population using Part A claims data. Depending on which type of hospital you represent, PPS or critical access, there are also quarterly or annual readmission trends, and we'll cover the differences between the PPS and critical access hospital reports in the next few slides. Also included are patient population segments by certain diagnoses, by certain categories such as demographics, hospital length of stay, and diagnoses, acute care utilization trends, and top diagnoses by discharge volume for readmissions, inpatient admissions, and emergency department visits. Analysis in this report is based solely upon your Medicare fee-for-service patient population only. This does not include solely Medicaid or Medicare Advantage patient populations. Dual eligible or patients that are Medicare and Medicaid eligible are included though. And we also want to mention that there is about a 5-month lag in the data upon the release of this report. Claims data is released to us on a quarterly basis, but it does take a few months for the data set to mature completely. So there is a gap by the time that we are able to run and distribute these reports. In your report, you may see some cells within some of the tables or charts that have the word suppressed in them. We suppress these cells to be compliant with CMS policy for protecting implicitly identifiable patient information. Therefore, any cells with values less than 11, except for those in which the hospital already has the information, such as the number of patient discharges, are suppressed. We understand that this does impact the value within the report, but we have taken steps to mitigate this and will continue to do our best to provide you with the most effective analysis while still complying with policies that protect patient data. This is just an example of a page within the report that has suppressed cells. Every cell within it has the word suppressed in it contained a value of less than 11. Not only do we have to suppress the cells with values less than 11, but we also have to suppress all cells that are associated with these suppressed cells. For instance, on this page, not only do we have to suppress the readmissions within 30 days of discharge cells because they are less than 11, but we also have to suppress the hospital grade cells. We do this because one can easily determine the number of readmissions by calculating the readmission rate with the number of patient discharges. Unfortunately, this does suppress a portion of report contents, especially for hospitals with lower patient volumes. Like I had mentioned, we will continue to work to address this and are open to feedback on ways to provide you with the best analysis. There are minor differences between the readmission report versions that the PPS hospitals receive with those that the critical access hospitals receive. And like I had mentioned, hospitals with lower patient volumes are going to have more suppressed cells. One way that we have tried to mitigate this is by aggregating time periods so that the values are larger and that we can share more data. So really the only real difference in page content between the PPS version of this readmission report and the critical access hospital version are the quarterly readmission and acute care trends. And we'll go through these pages very shortly. But for the PPS hospitals, we show data results over periods of individual quarters. And for the critical access hospitals, we aggregate the data and show results over 4 quarter periods. This allows us to share more of the data and suppress fewer of the cells for the critical access hospitals. And really the important thing to understand here is that the data between both report versions is the same, and really the only difference is the amount of aggregation. Readmissions within the report are defined as an admission to an inpatient hospital within 30 days of discharge, either back to that same hospital or to another hospital for your Medicare fee-for-service Part A beneficiary population. Readmissions are all-cause and can be related to any diagnosis. In the analysis, we do not include those patients that have either died or have left against medical advice. And finally, we do not risk adjust our calculations. So I go back to one of the real benefits of these reports, and that's in helping you identify areas for improvement in reducing patient readmissions. Many of you are probably already using your own internal data to drive improvement processes, so this slide may not provide any groundbreaking tips for you. But for those of you who haven't, here are some general strategies that can be beneficial. The first is to look for patient segments or diagnoses that have higher readmission rates than your hospital's overall rate or state average. Population groups with substantially higher readmission rates are really the main drivers and can have the most significant impact on your hospital's overall readmission rate. Identifying highly readmitted patients or diagnoses can help you develop improvement strategies focusing on specific patient segments or diagnoses. Also, analyzing historical trends by looking at time periods can be very helpful. Oftentimes, high quarterly readmission trends coincide with internal factors such as staffing changes or shortages, or external factors that may be seasonal, such as the flu season. Studying historical trends can be helpful to understand how different periods in time have affected your hospital's readmission rate performance. And finally, the utilization analysis provided in the report can help you understand where your patients go after discharge and how many and from what setting type are being readmitted. Depending on these outcomes, you may identify a need to develop or strengthen relationships with post-acute services and providers that a significant number of your patients are being discharged to. And we'll discuss this more in depth as we go through the pages of the report. This is an example of a page within the report to help you follow along with today's presentation. On each page of the report, the name of your hospital and CMS classification number, or CCN, will appear at the top of the page, along with the data description of the page's contents. This description provides helpful information about the page's content and definitions that may also need more clarification. The data description allows you to share any page of the report as its own document, and as you don't need the entire report if you only want to share a portion or a single page of the report. I should mention that when we go over the report example, the data description that you see in your reports that describes each item has been removed in these slides so that the tables and graphs are more easily readable. Also, each of the reports pages have their own page number at the bottom right hand of the corner, and I will use these page numbers in the slides as we go through the report example. So now I'll go through an example of an entire readmission report. I also wanted to mention that the data in this report is not associated with any hospital, as we created a summary report so we can share this with everyone today. The cover page of the hospital report has the name of the hospital and the CCN for that hospital. It also has the name of the county that your hospital is located in, or if your county is participating in a coordination of care coalition, it has the name of that coalition. Many coalitions are county-based, but for those that are comprised of multiple counties, it includes analysis for those counties within that coalition. So for instance, the Milwaukee County Coalition consists of both Milwaukee and Waukesha counties, and both of those counties are used for the community analysis. And finally, at the bottom of the page, we have the overall time frame of the report. In this case, it covers quarter 4 2014 through quarter 3 of 2017. The table of contents is fairly self-explanatory, but I do think it is helpful to note that the report is broken down into two separate parts. The first being trends for readmissions, and the second being patient utilization. The introduction page for the report provides definitions and explanations for the contents. This is really the resource to go to if you need more information about what's in the report or how things are defined. This next slide, which represents page 3 of the report, shows the quarterly readmission trends for the PPS version of the report. Your hospital's performance is displayed quarterly on this graph for over the last 12 quarters. And your performance over these 12 quarters are noted as a dark blue line within the chart. The yellow line within the chart represents the overall 30-day state readmission rate for that quarter for the Medicare fee-for-service beneficiaries. The lighter blue or teal line represents the 30-day readmission rate for Medicare fee-for-service beneficiaries that were discharged from only PPS hospitals in the state. Critical access hospital discharges are not included in this lighter blue line. We did this so that you can see how your hospital performance compares with that of similar hospitals. So the PPS hospitals will be compared with other PPS hospitals, and we'll see in the next slide that the critical access hospitals will be compared to other state critical access hospitals. The green line in the chart represents the 30-day readmission rate for either the community or county that your hospital is located in. And finally, there is also a dotted line that indicates the best fit trend line for your hospital's readmission rate trend over the entire period in the chart. So in this case, the trend line is angled at an upward direction, indicating that the hospital overall readmission rate is at an upward trend or a rising trend over the last 12 quarters. Hospitals with better performance in terms of readmissions would see a trend line that has a downward angle. Now to the critical access hospital version of this chart. Nearly everything that I mentioned in the previous slide for the PPS hospitals holds true for the critical access hospital version. The hospital performance is in the dark blue line. Since this is an example of the readmission trend chart for critical access hospitals, the light blue line shows the readmission trends over the time period for only the critical access hospitals in the state. The yellow line is the state performance, and the green line is the county or community performance. The only real difference between the critical access hospital version and the PPS hospital version of this chart is that the data points are by rolling 4 quarters for the critical access hospitals. We rolled up the data for the critical access hospitals so that we could avoid suppressing data points. If we did not do this, we would have many more suppressed cells within this chart. And even rolling up to 4 quarters of data doesn't necessarily prevent us from suppressing some of the cells. On this specific chart, we can see that for the time period quarter 3, 2015 through quarter 2 of 2016, it does not have a data point. And this is because there weren't enough readmissions within the aggregated time period to share this data. So if you do notice any time periods without a dot or a point within the blue line for your readmission performance, you'll know that your hospital did not have at least 11 readmissions within that time period. This hospital readmission trend table represents the previous chart by showing the raw numbers of discharges and readmissions for each given time period. Since this is the PPS version, the chart is broken down by single quarters. For each quarter, we have the number of discharges, all-cause 30-day readmissions, and readmission rate for your hospital's Medicare fee-for-service beneficiary population. Also, readmissions to the same hospital or patients that were discharged from your hospital and then readmitted back to your hospital are displayed along with their rate. This helps give you an idea of what proportion of your patients are being readmitted to other hospitals. And finally, at the bottom row of the table, it sums up all the data on the columns of the table over the entire time period, so you can have an idea of how well your hospital performed over the last 12 quarters of data. Here's the critical access hospital version of the readmission trend table. As you will notice, the numbers in the cells are significantly smaller than the PPS version that we showed in the previous slide. And this is because the patient volume of critical access hospitals can be significantly smaller than their PPS counterparts. Even with the rolling 4 quarters for each time period, we still have some suppressed cells as we do in this particular table. Also, another difference from the PPS version, the critical access hospital version does not have a row at the bottom of this table that accumulates the totals for the overall time period. We did this because if there were any suppressed cells within the table, accumulating the totals over all the time periods would skew the readmission rate because we would not be including those readmissions within the suppressed cells. But overall, the table is very similar between both the PPS and critical access hospital version. The only difference, again, is the amount of aggregation. Starting with page 5 of the report, we begin to show pages that are identical for the reports for both the PPS and critical access hospitals. This particular table, the detailed readmission snapshot, displays demographic statistics for your Medicare fee-for-service patient population over the last 4 quarters, so in this case, quarter 4 of 2016 through quarter 3 of 2017. For any Medicare patient discharged from your hospital within this period, their demographic breakdown is part of the analysis displayed on this table. The population segments are broken down by categories such as race, age, sex, and so on. Patient volume in terms of hospital discharges and readmissions for each category are displayed along with the corresponding readmission rate in the second to last column. This table can be helpful in a number of ways. First, it helps you understand the demographics in terms of your patient volume. You may notice that certain categories represent a proportionally high percentage of your overall patient discharges. And if this group of patients has a higher readmission rate than your overall hospital rates, there's a strong chance that this group of patients is having a strong negative impact on your overall hospital readmission rate, and you may choose to focus on this group of patients for quality improvement efforts. Finally, the last column in this table displays the statewide 30-day readmission rate for each category. You can use this column to compare your hospital's readmission rate performance with that of the state average to determine how well you are doing for each demographic category. Page 6 has a table that is a continuation of the previous demographic table. While the previous table focused on patient demographics such as patient age, sex, and race, this table is more centered around patients by diagnoses. In this table, there is a list of some of the more common diagnoses that are related to high hospital readmissions. The diagnoses in this table are standard for all hospitals that receive this report. Any Medicare fee-for-service patient that is discharged from your hospital within this time period, so in this case is quarter 4, 16 to quarter 3, 2017. So any patient that is discharged from your hospital within this time period that had any one of these diagnoses would be included in this analysis. The diagnosis does not have to be a primary diagnosis at admission. It only has to be documented within that patient's problem list. So that is why the diagnosis is labeled as any diagnosis. A single patient with multiple diagnoses included in this chart will be represented for multiple conditions. So, for instance, a patient discharged from this hospital who has both asthma and sepsis in their problem list will be represented for both diagnoses in this table. Much like the previous demographic table, the statewide rates are also provided in the last column for comparison. When using this table for quality improvement, identifying diagnoses with high patient discharge volumes along with high readmission rates would again be a good place to start. So, for example, if the overall readmission rate for this hospital is, let's say, 16%, identifying readmission rates for patients over 16% would be a good place to look at. And by looking at this particular table, patients with hypertension at 54% of the overall discharges and also a higher readmission rate at 19%, this would be a logical focal point for a quality improvement initiative because there's so many of these patients in terms of numbers, and the high readmission rate indicates that there is real room for improvement. I also did want to mention that for the folks here representing the critical access hospitals, we are aware that many, if not all of these cells in these tables are suppressed due to lower numbers. We do apologize for this, and we will continue to improve upon these reports to add as much value as we can while still following CMS guidelines. So if you do have any suggestions on how to make this table more valuable for you, we would greatly appreciate your feedback. The next table on the report categorizes the top 10 CCS or clinical classification software level 3 categories by discharge count over the last 4 quarters of data. The diagnoses in this table are primary diagnoses at discharge. For each diagnosis, the number of discharges, readmissions, and corresponding readmission rate are displayed. The state rate for each diagnosis is also listed, and the last column in the table displays the next top diagnosis cause for a readmission that was not the original or admission primary diagnosis. So, for instance, patients analyzed in this table, those that had a primary discharge diagnosis of septicemia, for the 46 patients that were readmitted, the next top cause for readmission after septicemia is hypertension. This can help you identify some of the other causes for readmission that aren't the same as the diagnoses at discharge. This table is helpful in that it lists the top diagnosis-related causes for readmission for your hospital. For quality improvement purposes, using this table as an example, while the septicemia patient population is responsible for most patients discharged over this time period, we see that the readmission rate for these patients at 18.5% is only slightly higher than the state rate at 17.3%. Possibly a better diagnosis to focus on that would have a greater impact on overall readmission rates would be respiratory failure. While respiratory failure patients do not make up as many discharges as those of the septicemia patients, it does have more readmissions with 61, and the readmission rate of 32.8% is significantly higher than both that of septicemia and the state average for respiratory failure patients. Closing this gap in terms of readmission rates for the respiratory failure patient population would be a logical choice for a quality improvement project for this particular hospital. The next table in the report displays top diagnoses by number of discharges, so the same 10 diagnoses from the previous table, and lists to which setting the patients are being discharged. The setting categories are home, skilled nursing facility, and home health agency. We also see that for each discharge setting, there are a number of readmissions and the corresponding readmission rate. For instance, looking at septicemia, we see that 82 patients with a primary discharge diagnosis of septicemia were discharged to home, with 11 being readmitted back to the hospital from the home setting for a readmission rate of 13.4%. 72% of septicemia patients were discharged to a skilled nursing facility setting, with 20 of those being readmitted for a readmission rate of 27.8%, and so on. So this table is helpful in that it provides information for patients of certain diagnoses and where they go after discharge from your facility. It also helps you understand for what diagnoses and discharge settings where there may be gaps or opportunities to improve. For instance, if we look at this table, we can identify some of the cells with the higher readmission rates. Patients discharged from this hospital to the nursing home setting with a primary diagnosis of hypertension were readmitted at a rate of 36.4%. This may encourage this hospital to reach out to nursing homes in their community to develop a better working relationship, especially concerning their hypertension patients that are discharged to the nursing home setting. On this table, just looking at the other discharges to nursing homes in general with these other two diagnoses, septicemia and renal failure, also having high readmission rates, it really might be a good idea for this hospital to strengthen communication and relationships with nursing homes in general. These are just some of the basic ideas of how to use this information to identify any areas for improvement with post-acute organizations. This table represents the state averages for the top 10 diagnoses by discharge, and this is the same top 10 list listed in the previous two tables in your report. And it just displays the discharge settings and respective readmission rates. This allows you to compare your hospital's performance with that of the state average for diagnoses and readmission rates by setting type. Page 10 is a chart that displays the 30-day any acute care utilization rates for the Medicare patient population. And we'll go over the PPS hospital version first. We defined any acute care utilization by aggregating all inpatient admissions, emergency department visits, and observation stays within 30 days of hospital discharge. So for patients being discharged from your hospital, if they had any of these three encounters, either an inpatient stay, an ED visit, or an observation stay within 30 days after discharge, that would classify as an any acute care visit. This table helps give you an overall idea of how many of your discharge patients are using acute services within that 30-day discharge window. For the PPS version of the report, much like the readmissions trends chart, the any acute care utilization rates are charted by quarter. and compared with the state rate for over the last 12 quarters. The hospital rate over this time period is once again in the dark blue line with the state average in yellow. Also, there is a trend line indicating the overall trend of the any acute care utilization rate across the entire time period. Here's the same chart, only for the critical access hospitals. Once again, it provides the same data, any acute care utilization, only that the data points are aggregated to rolling 4 quarters. The state 30-day rate is still the yellow line with the hospital rate being the blue line, and once again, there is also the dotted trend line that represents the any acute care utilization rate trend over the entire time period. Page 11 has the table with the raw numbers that are used in the any acute care utilization chart. This is the table that is seen for in the reports for the PPS hospitals. So in this table, for each time period, in this case by quarter, there is a breakdown of the any acute care utilization categories. For every time period, we have totals for inpatient admissions, ED visits, and observation stays with their respective utilization rates. And finally, we have a total of these 3 acute care encounters in the any acute care visit column with the overall rate at the right end of the table. Finally, for the PPS version, we do have the totals over the 12-quarter time period at the bottom of this table. And here we have the acute care trends after discharge for the critical access hospital report. It is nearly the same table as the PPS version, just once again, the only difference is that the time periods are aggregated by rolling 4 quarters. We still have the any acute care utilization categories, the inpatient stays, ED visits, and observation stays for each time period, along with the overall any acute care utilization and that rate as well. The final 2 pages of the report are kind of an offshoot of the any acute care utilization trend analysis. Starting with page 12 of the report, we have the table for the top 10 clinical categories for inpatient stays by discharge count. This lists by discharge counts the top 10 most common diagnoses responsible for inpatient stays. And for each diagnosis, readmissions and readmission rates are also listed along with the state rates for comparison. Also included in this table, ED visits and 30-day ED utilization rates, along with the state rates for those categories as well. And finally, the any acute care 30-day utilizations and rates are provided for each diagnosis along with those state rates. You can use this information by selecting the inpatient diagnosis with the highest any acute care rate as a potential focus area. In this case, complication of device, implant, or graft not only has the highest any acute care within 30 days among the top high volume discharge diagnoses, but its rate is also much higher than the state rate, so these patients and their care could merit review. And finally, the last page of the report lists the top 10 clinical categories for ED visits. These clinical categories are somewhat different than those that are responsible for the inpatient visits, as obviously more of the diagnoses that are related to having a patient go to the ED are related to such things such as pain, fractures, and other injuries. For each of the clinical categories, there are totals for inpatient stays, ED visits, and the aggregated any acute care encounter within 30 days of discharge, along with their respective rates and state rates for each. You can use this information here as you may have used the information in the previous table by identifying a diagnosis with a high acute care follow-up rate as an opportunity to look into that patient population and the care that they experience as a result of receiving that diagnosis in the ED setting. In this example, abdominal pain would be a logical focus area to select, given its any acute care within 30 days rate is higher than any other diagnosis rate, and the state rate for that diagnosis. So that kind of wraps it up is providing an example of the report. We at the Lake Superior Quality Innovation Network want these reports to be beneficial to you and your staff. Really, the main goal of this report is to provide hospitals with as much useful information that can be applied within their facilities and used to drive quality improvement efforts and reduce readmissions. That being said, we do realize that there are some real limitations within the report, especially for critical access and smaller PPS hospitals. There are pages within the report that lack valuable content due to small patient volumes and suppression in the Rule of 11. We are aware of these limitations and will continue to make improvements upon these reports, but any feedback that you provide us will be greatly appreciated and will help us improve future iterations of this readmission report. Our contact information is available at the end of this presentation, and we encourage you to reach out to us if you have any feedback you'd like to suggest. These are the tentative dates for the readmission report distribution through the rest of the year of 2018. This June, we will have our next report sent out to the hospitals, and that report has Medicare fee-for-service claims data analysis through the fourth quarter of 2017. In September of 2018, we'll have the report with claims data through the first quarter of 2018. And finally, in December, we will provide the reports with data through the second quarter of 2018. So expect to receive a readmission report from us once every quarter or 3 months. And that concludes the main portion of our presentation. With that, we would like to open things up for any questions, comments, or feedback from the audience. So Richard, if you wanted to open it up for questions, that would be greatly appreciated.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touchtone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touchtone phone. Standing by for questions.
Thank you. I do realize that I did throw a lot of information at everybody, so it might be hard to kind of digest everything within the report at once. So once again, we have our contact information up here. Feel free to reach out to either myself or one of your state contacts within the LSQIN, and we'd be more than happy to provide answers or requested responses at that time.
Our first question online comes from Barb Mulder. Please go ahead.
Hello, Barb.
Hello. We are in Kalamazoo, Michigan, and I was just looking at my report prior to the call, and it says name of community county Battle Creek. That is incorrect. I'm just hoping that the actual data within the set would be correct, because not only is the hospital in Kalamazoo, that's also the county it's located in.
Okay. Well, the information provided to you in regards to your hospital would be correct. The only difference is that the community or the county analysis would be that of Battle Creek and not of your correct county. So we will work on making that change for your next report.
Yeah, that would be great, because our comparison would be with our hospital here in Kalamazoo. We have another hospital here in Kalamazoo that we would want to be sure that the comparisons were within our community.
Yes, and thank you for your feedback. And like we said, this is the first iteration of this report, so we do expect some minor kinks.
No worries.
We'll make that adjustment.
Yeah.
Thank you, Barb. We did also want to encourage you to complete the evaluation that is on the right side of your window. We use the feedback that we received from the evaluation to improve upon our processes and make improvements and adjustments to future learning sessions. So we would appreciate if you took just a couple minutes to fill out that evaluation.
Thank you. Our next question online comes from Tammy Suki. Please go ahead.
Can you hear me?
Yes, I can.
Beautiful. Can you remind me again what the cutoff is when the data is suppressed? I'm from a critical access hospital, and I was a little late getting on the call and didn't catch that number.
Yes, well, that's a great question, and thank you for bringing it up. The policy that CMS uses, they determine that the number, and we're not really quite sure how they came up with the number, but it is any cells with values of less than 11 are suppressed because those values less than 11, CMS has deemed that they are implicitly identifiable. So we are restricted from sharing that information if it is under 11 because these readmissions, the readmission data does include readmissions to other hospitals. So technically that information belongs to those hospitals. So we are limited to sharing cells with values of less than 11. But thank you for asking.
Thank you.
Welcome.
Thank you. Once again, for any questions or follow-up questions at star, then 1 on your touchtone phone. Our next question online comes from Chris Leahy-Ross. Please go ahead.
Hey, Ross. Chris Leahy-Gross from UW Hospital. Hi, Ross. Couple questions related to the benchmarks. So one is the state 30-day readmission rate. I'm assuming this includes critical access hospitals?
Yes. If you are representing a critical access hospital.
The state includes both.
Okay, I'm sorry. Thank you.
State 30-day readmission rate. Who does that include?
That would include all hospitals within your state.
All hospitals. So then the Wisconsin acute care group, that is a subset of the state 30-day? That's a subset of the state.
Yes, that would be a subset of the state.
Define who's in the Wisconsin acute care group.
So it would be all hospitals that are acute care or PPS.
So that's non-critical access hospitals, essentially?
Yes.
Okay. So regardless of, so it's community hospitals, there's no bed size limit, it's every hospital in Wisconsin that's not a critical access hospital?
You said community hospitals, or did you mean?
Yes, community hospitals. So it would include Dodgeville Hospital, every hospital in Wisconsin.
So there are, maybe I'm not understanding the question, but there are three benchmarks that we're using besides your own data. One is the state benchmark, which is all hospitals within the state. And there is, if you're acute care, then there's acute care, or if you're critical access, then it's critical access, which essentially compares you to your type of hospitals within the state, so it's a subset of the state. The community benchmark is the readmission rates of beneficiaries that reside within your community. So that's not restricted to hospitals within your community. That is based on the zip codes of your beneficiaries.
Okay, got it. So just to follow up then, so when we're looking at the Wisconsin acute care group, the hospitals in that group, that includes hospitals with perhaps 20 beds all the way hospitals up to 500 beds.
Yes, there is no bed size limit on that. That is correct.
Thank you.
Thank you. Our next question online comes from Charles Haka, MD. Please go ahead.
Hi, I'm in a critical access hospital in Wisconsin, and we do admissions for swing beds. Are swing bed admissions considered in this data as well?
I would have to double check on that. I'm not entirely sure. They're not. The claims, if we're talking about claims, those are included in the analysis, but we do not separate them out, or we do not analyze them separately. But we do include all claims within the analysis. That are part. Medicare.
In that sense, I think you can understand. We have a central hospital in Green Bay that someone might have been there for an orthopedic surgical procedure, and then to want to get closer to home out in our rural area, they are discharged and then, in a sense, readmitted to our swing bed unit. But it really is a part of the same process, and I wondered if that affects our data.
If that would be classified as an inpatient admission, then that would count as a readmission. If it's within that 30-day discharge window. But that is another great question. And if you wanted to send me an email after the call, we can address the question directly.
Great.
Thank you.
Thank you.
Our next question comes from Rob Barrett. Please go ahead.
Hi, this is Rob Barrett from Henry Ford Health System in Michigan. I just had a couple of questions about the detailed readmission snapshot part 2. Some of the statewide 30-day readmission rates for some of the diagnosis categories just seem incredibly inaccurate, like single digits for things like CHF and COPD. Who would I contact to look into this data a little bit further?
Well, that is you would just to let everyone know that some of the values within this report are we made them up just so that we could create a dummy report. But I do think the state rates are actually run through an analysis, aren't they?
Yes.
Yeah.
But if you do feel that your data is inaccurate for state or your own hospital, feel free to contact us at the back end. My name is Rahul Paul, and my email is at the end. And you can feel free to contact me or send me.
So that was Rahul Hall.
Rahul Paul.
All right. So I'm just online through the phone, and I was able to download the slides. So, all right. Thank you.
We have your email too that we can respond to you directly to.
Perfect. Thank you very much.
Welcome.
And at this time, I see we have no questions in queue.
Okay. I think we'll give it another minute or so in case anyone's gathering some thoughts and kind of working things out. But these are all great. This is all great feedback from just the 4 or 5 questions that we've received. And like I said, it's the first time we get this out. We didn't expect it to be a perfect report. But that being said, we're gonna work our best to maximize the value and get everything down pat so that we can have this standard report. Have it become a reliable source of information to drive your QI efforts going forward. So if we don't have any other remaining questions, I think we could wrap up today's event. I do once again want to encourage everyone to please fill out the evaluation. We do really appreciate the feedback, and we do use that to make improvements within our process at the LSQIN.
Pardon me, but we have a question that just queued up from Randy Claiborne. Sure. Please go ahead.
Yes, we're part of a larger organization, but part of our organization also has a critical access hospital. And I was just curious, when you create the report, is it comprised altogether, or would the critical access numbers be separate?
So critical access hospitals some systems do have both PPS and critical access hospitals. But critical access hospitals are only compared with other critical access hospitals in the state, and the same holds true for the PPS hospitals.
Okay, so the numbers are not brought together. Okay.
No, yeah, you are correct.
All right, thank you.
Thank you. And are there any more questions?
And we have no further questions.
Okay, well, I just wanted to thank everyone for showing up at today's educational session. Remember that the PowerPoint presentation is a WebEx handout listed under the event materials. And this recording of this event will be available on the LSQIN YouTube page in approximately a couple weeks or so. Once again, please take a moment to complete the evaluation and provide your feedback to help us making these events as effective as possible. Thank you all for attending and have a great day.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.